Today, we're going to be talking about IV fluids and electrolyte repletion. Let's get started. Please have your phone ready to scan a QR code. If the QR code does not work, type in the link provided on the slide. Some disclaimers. This lecture includes my approach to giving fluids. Every attending will have a different preference. Fluid physiology is really complex, so this is a somewhat simplified approach, and ask your attending their approach to giving fluids. It's a great way to learn about different practice styles. So by the end of the session, you're going to be able to describe the components of an IV fluid timeout, recognize indications for repletion of electrolytes, and demonstrate how to replete electrolytes that require monitoring. So let's talk about what an IV fluid timeout is. So it's an approach I made, and you ask yourself 4 questions before you decide to give IV fluids. So it's a framework. First question is, what is the indication for giving fluid? Second is, what is the approach for intervening? The third is, what type of IV fluid should I give? And 4 is, how much IV fluid should I give? So let's go through these piece by piece. So what is the indication for administration of IV fluid? Well, let's go over 2 main indications. So low preload, leading to vital sign changes and/or symptoms. The other is disrupted oral intake for an extended period of time. So perioperative period, being ventilated, things like that. It's an important caveat here. You do need to consider aggressive IV fluids for nephroprotection in specific situations like tumor lysis and hypercalcemia. Once you've decided on an indication, you can move on to the next step. Before we do that, we have to ask ourselves, well, what do low preload states look like? Well, there's great surgical literature that actually I got this table from, where it's the expected physiologic response to blood loss in a 70-kilogram patient. Depending on how much volume you lose, you start getting progressive vital sign changes. So your heart rate is the first thing to go up. Then it's actually your respiratory rate. Then your blood pressure starts to drop. Your urine output starts to drop, and then you can become altered. Now that we know what the indication is, we can ask ourselves, well, what is the approach for intervening? And there are 2. Resuscitation if you have low preload, and maintenance if you have disrupted oral intake. So they kind of match up nicely to the first question. Please realize some patients will need resuscitation followed by maintenance. Someone comes in for terrible diarrhea and they're hypovolemic, you may give them resuscitation. And after that, maybe they're going to be NPO for a procedure. Maybe you need to give them some maintenance fluid. We're already on to the third question. What type of resuscitative fluid should I give? So we'll talk about the type and amount of resuscitative fluid and the type and amount of maintenance fluid. So there are a couple of types of IV fluid for resuscitation. So I want to go over them briefly. Under fluids, you have colloids and crystalloids. And then under colloids, you have the main one that we use is albumin, and then crystalloids, normal saline, and balanced crystalloids. And underneath that is lactated ringers, also known as LR, and plasmolite. Of note, gelatin and dextran have been pulled off the US market, so don't worry about that. One thing I really want to emphasize here is that colloids are not superior to crystalloids for volume resuscitation. So you may think albumin is better. It is not for volume resuscitation. Let's talk about crystalloids again a little more. So to review, well, under crystalloids, you have normal saline and balanced crystalloids. And under that, you have LR and plasmolite. Well, why is it called normal saline? Well, folks thought that the 0.9% concentration of salt was equal to the concentration of salt in the plasma. That is not correct, so it's technically not normal. LR and plasmolite are thought to be balanced because the sodium, potassium, and chloride content are closer to that of extracellular fluid. So we're going to take each fluid and juxtapose it to plasma, and I'm going to highlight a couple of the notable things. You'll see them in red. So you'll notice that normal saline has a super high chloride content compared to that of plasma. So we have to talk about the implications of that. So can normal saline cause a non-anion gap metabolic acidosis? It sure can. After you give a lot of normal saline, the plasma can become hyperchloremic and the patient will develop anagma. Can normal saline cause AKI? It's a weird question to ask. We're resuscitating someone. It should always help. Well, hyperchloremia can theoretically lead to decreased renal artery perfusion, but there's a lot of conflicting data in the literature, so jury is still out on this one. Final thing is, can it cause hyperkalemia? And you may be asking yourself, well, there's no potassium in here. What's going on? Well, the patient has anagma. Potassium can exchange with excess hydrogen in the blood. So the potassium shifts into the blood and then your potassium goes up. It's obviously not good. Let's move on to LR. You'll see that the potassium, the lactate, and the osmolarity are all in red. So let's go over some things. Can LR cause hyperkalemia? I mean, there's potassium in it. Remember that the potassium in LR is 4. So if we're talking about concentrations and equilibration gradients, your potassium might actually go down if you give LR. So if someone has a potassium of 5 and you give them if you give them LR, their potassium will drop. All of this is to say that it is safe to give hyperkalemic patients LR. So don't be deterred by that. Can LR cause lactic acidosis? The answer is no. And that goes to the type of lactate in LR. So the lactate in LR is actually sodium lactate, not lactic acid. So a little chemistry refresher. An acid has to be able to donate a proton. Sodium lactate is sodium and lactate ion, so it can't donate a proton. I will say that patients with liver failure cannot actually clear sodium lactate, so the serum lactate cannot be reliably interpreted once you give LR. This is specific to patients with liver failure. And can LR increase your ICP? Well, the osmolarity of LR is lower than that of plasma, so you end up getting fluid shifts. So if a patient has a TBI, for instance, you might want to consider avoiding giving LR. Let's move on to plasmolyte. Potassium is higher than that of LR, and the pH is pretty close to that of blood. You have to ask yourself again, can plasmolyte cause hyperkalemia? The answer is no, for the same reason that LR does not. Second thing is this preferred over LR in patients with a metabolic acidosis? I mean, the pH is closer to that of blood, so maybe there's something there. It might be preferable. As a refresher, the pH of LR is 6.5. It was in the previous slide. This is that closer to that of blood. The literature doesn't actually support it, so it's hard to say. Lastly, this is not often available on med-surg floors, but readily available in operating rooms. So accessibility might be a consideration depending on how quickly you need this fluid. So this is a composite of the different compositions of resuscitative fluid. This is a more important summary slide. So the only one that can cause hyperkalemia is normal saline. The only one that can cause anagma is normal saline. None of them cause a lactic acidosis. Do not use LR if you want to trend a serum lactate in a patient with cirrhosis. Do not use LR if a patient has elevated ICP. And we have no idea what is preferred in patients with metabolic acidosis. I will say this can cause hyperkalemia thing, requires you to give a lot of normal saline, so it's still probably safe to give. A lot of people still do it. Let's talk about how much fluid to give now. Well, you have to think about what drives fluid into vessels first. So osmotic pressure keeps fluid in the vessels, and hydrostatic pressure drives fluid and solute out of the vessels. So if you look at the distribution of IV fluids, a crystalloid like LR, plasma, light, normal saline, if you give a liter of that, only a quarter stays in the blood. It's pretty wild. Colloids like albumin, however, completely stay in the blood. So if you gave a liter of albumin, it all stays in the blood. You may wonder, well, what's the point of thinking about this? You'll find out a little bit later, but I do want to reiterate here that colloids are not superior to crystalloids for resuscitation, despite this fact. So our bodies are somehow able to reaccommodate this fluid in the future. So how much fluid do you give? Well, it's classically taught to give septic patients 20 to 30 cc's per kg of their weight. You have to be careful in patients with heart failure, renal failure, and cirrhosis. They can't necessarily accommodate all that fluid. This number may fall out of favor soon, it's hard to say. And remember, some patients may actually require more than this recommended amount. So don't be afraid to give more if you think it's necessary. If there are no guidelines to help you decide, you have to give an arbitrary amount of fluid and then come back and reassess. So anywhere from 250 to 1,000 cc's. Remember, you can just keep coming back. You can give 250, come back and see the patient, 250, come back and see the patient, and keep doing that until you're sure. Let's shift over to maintenance fluids. So what type of maintenance IV fluid should I give? Fortunately, there's really only one that we use, D5, half normal saline. It's half normal saline with a little bit of sugar. Sugar is there because you need glucose to suppress catabolism if they're not eating anything. And you should think about adding potassium if they have a lot of GI or urinary losses. So patients with a lot of diarrhea, with polyuria. How much maintenance fluid should I give? Well, we have a rule. It's a pediatric rule based on a study done in 1957, and it is still used to this day. For the first 0 to 10 kgs, you give 4 cc's per kg per hour. The next 10 to 20 is 2 cc's per kg per hour. Everything above that is 1 cc per kg per hour. So I'm an internist. I take care of patients greater than 20 kilograms, so there's a shortcut. Your maintenance rate is the weight in kilograms plus 40. So if I have a 40 kilogram patient, the maintenance rate is 40 plus 40, 80 cc's per hour. So let's review an IV fluid timeout. So step 1 is to look at the indication. It's either low preload or disrupted oral intake. Step 2 is do you resuscitate or maintain? Step 3, the type of fluid. So colloids are not superior to crystalloids. LR seems to be the way to go for a lot of reasons, unless patient has cirrhosis and you want to trend to lactate, or if they have an increased ICP. The only maintenance fluid we use is D5 half normal saline. For the amount of fluid, you should give it in increments if you're resuscitating, or if you're in sepsis, if patient has sepsis, you give 20 to 30 cc's per kg. Remember, use extra caution in patients with heart failure, renal failure, and cirrhosis. And then for maintenance, you can calculate using a 4-2-1 rule. So it's time to practice. You can scan this code or use this link if you're using a computer. And let's talk about the first case. We have a 38-year-old male with a history of hypertension and diabetes coming in for right flank pain. He's had pain with urination for 3 days and then developed right flank pain right before coming into the ER. He has subjective fevers and dizziness when he stands up too quickly. Denies cough, diarrhea, constipation. Temp of 39, blood pressure 90/60, heart rate of 120, respiratory rate of 16, stating 95% on Romer. He has dry bilateral axillae, tachycardic with regular rhythm, right flank tenderness to palpation. His potassium is 4, his creatinine is 1, his white count appears to be high, 18, and his serum lactate is elevated. So we're going to go through the 4 questions. I'm only trying to commit to them on the survey and the QR code. So we're going to go through each question. I'll give you a hint. So what is the indication for giving fluid here? Well, the patient likely has sepsis due to pyelonephritis. Fun fact, urosepsis is often used to describe this term, but it's not a billable diagnosis. So in your notes, please call it sepsis secondary to urinary tract infection. Second is, what is the approach for intervening? The hint here is that the patient lacks fluid in his vessels, so hopefully that helps. 3 is, what type of IV fluid should I give? K is 4, creatinine is 1. So they seem to be normal, and he's an elevated serum lactate. How much fluid should I give? Well, as a reminder, the patient has sepsis secondary to pyelonephritis. So go ahead and submit your answers. There's something to be said for committing to an answer and submitting it before we review them. It helps consolidate your memory and review what you did correctly or incorrectly. So the indication for giving fluid here is low preload from sepsis. The approach for intervening would be resuscitation. The type of fluid, probably LR is good. Patient has a normal potassium, but that doesn't even matter. Patient does not have cirrhosis, so if you want to trend the lactate, you can. You should give 20 to 30 cc's per kg. So now let's move on to case 2. We have a 76-year-old female with a history of heart failure with reduced EF due to ischemic heart disease who comes in with nausea and diarrhea after trying food at a local food truck last night. She takes all her heart failure medications and did not take her diuretic this morning because of the excess diarrhea. She is still unable to eat and had 10 watery bowel movements since her symptoms started. Temp of 37, blood pressure of 90/60, heart rate of 90, respiratory rate of 16, O2 sat of 96% on Romer. JVP is 2, tachycardic with irregular rhythm, dry bilateral axillae, diffuse abdominal guarding, and no rebound tenderness. Her potassium is 5, creatinine is 1, and her serum lactate is elevated. So what's the indication here? Remember that she had many watery bowel movements and she's unable to eat on her own. What is the approach? She appears dehydrated on exam. She has bilateral dry axillae. What type of fluid should I give? Potassium is 5, normal kidney function, does not have cirrhosis. How much fluid should I give? Remember, she has heart failure with reduced ejection fraction. So if you think of your Frank-Starling curve, the left ventricle has to overcome the pressure in the aorta to push blood forward. So if your ejection fraction is really low, your body actually functions better with the lower afterload. So your goal blood pressure in patients with a low EF can be anywhere from 90 to 100. So much lower than your classic 120. Go ahead and submit your answers and we'll review them. So the indication here is low preload from diarrhea. So if you're in a low preload situation, you have to resuscitate. You can still give LR here. The patient's hyperkalemic, but there's no reason to avoid LR. How much fluid should I give? The answer here is actually a little, so probably 250 or so. You wouldn't, I think a liter would be a little too much. Remember that it's easy to give fluid multiple times and reassess, but once you give too much, it's much harder to go back. So that's it for fluids. Now let's shift over to electrolyte repletion. So here's an electrolyte panel. You're going to be seeing this a lot on your medicine service. So this is where everything is. The items in red are what we are going to talk about because that is what we replete. You see the Chem7 BMP, that's the sodium, potassium, chloride, bicarb, and creatinine and glucose. This is also known as an anion gap panel at the VA. Big shout out to the VA where I am. A Chem10 is a Chem7 plus 3 things, a calcium, a mag, and a phos. I really want to urge you to not check these daily on every patient. Only check them and monitor them if there is a specific indication. So very often we do get labs daily, but there's a good reason. Once those reasons stop, you should stop checking labs. Let's start with potassium. So the main 4 indications for checking are cardiac conditions, low magnesium, active diuresis, and diarrhea. I'm not going to read the rationale to you. There are certain times when we have a specific potassium goal. It's greater than 4 if acute MI or cardiac conditions, and greater than 4.5 if VT. So cardiac conditions is vague on purpose because no one can agree. So if your patient has a history of coronary artery disease or something like that, it's okay to give greater than 4 as a goal. So how do you replete it? Well, there's an equation, luckily. Goal potassium minus actual potassium divided by your creatinine times 100. And that's how many milliequivalents of potassium chloride to give. Notably, if your creatinine is less than 1, you just divide by 1. We're going to be doing some exercises later to practice this. So how do you increase your potassium level? So you calculate how much you need, and then you can give it orally. If you're going to give a pill, ask the pharmacy to give it in 10 milliequivalent pills. So if it's 80 milliequivalents to replete, it's going to be 8 pills. Otherwise, the pills are huge. Or you can give a solution which apparently tastes really bad. Alternatively, you can give it IV, but it can cause a burning sensation. If you give it peripherally, you can give 10 an hour. If you give it centrally, so an IV in the neck, you can give up to 20 per hour. The patient also has a low magnesium. You have to replete the magnesium before you replete the potassium. This is a really important point. So replete magnesium before you replete potassium. Now let's talk about magnesium. The 2 main indications for checking it are an active diuresis or diarrhea. There are specific magnesium goals, just like there were potassium ones. So greater than 2 if CAD or active cardiac conditions, again, pretty vague. Then greater than 2.5 for VT, which stands for ventricular tachycardia. There's a magnesium repletion equation that is for IV magnesium only. So the goal mag minus the actual mag divided by the creatinine times 10. And that's how many grams you give. So if the creatinine is less than 1, you just divide by 1. So how do you increase the mag level? So you can do it orally, only if patients do not tolerate IV. Oral magnesium is pretty ineffective. There's 2 main formulations: magnesium oxide, which can cause diarrhea. And as you saw on the last slide, diarrhea can actually cause magnesium loss. So I think overall there is still a net gain of magnesium, but it's not that much. So you can dose it, it's pretty arbitrary, 400 to 800 milligrams daily. Then the other thing you can do is magnesium protein complex. This does not cause diarrhea because it is complexed with protein, but it is not available everywhere. So there's 2 different formulations here. So the VA has magnesium oxide, UCLA has magnesium oxide and mag protein complex. The other option is you can give this IV and it does not cause a burning sensation, unlike potassium. So calcium, the indication for checking this most of the time is tumor lysis. You should correct the calcium for the albumin before deciding if it is abnormal. So calcium is positively charged and albumin is negatively charged. So there is some sort of effect there. So before you decide, hey, this is high or low, correct it first. How do you increase the calcium? Well, there's not really a good oral repletion. And the 2 IV ones we have are calcium gluconate and calcium chloride. There's no need to replete this unless the patient is symptomatic from hypocalcemia or if their QT is prolonged. So that's on an EKG. Only give 1 gram of calcium at a time. Phosphate is the last one. The two main times to check are concern for refeeding syndrome and CRRT for low phos. Phos repletion is very complex. I assembled this table to give you all the oral and IV options. I think the things to really pay attention to here are if you look at the middle, depending on how low your phos is, you give a more aggressive repletion regimen, which kind of makes sense. The other thing to notice is that most phosphate repletion has potassium in it. So someone has a potassium of 6, but their phos is low, you should probably just give sodium phosphate because you don't want to add fuel to the fire in terms of the hyperkalemia. So this is going to be available to you as a reference, so don't worry. So it's time to practice again. So go back to your survey. Hopefully you didn't close it. We have a 24-year-old female with no medical conditions who comes in with septic shock due to pneumonia. Her kidneys fail and they are now recovering. During recovery, she develops a lot of urine output. Her electrolytes are as follows. So what needs to be repleted? So look at the potassium, it's 3. Calcium is 7.6. The mag is 1, and the phos is 3. So how do you replete them? So to replete the potassium to the lower limit of normal, here is the equation. Here is the equation for the corrected calcium. And here is the equation to replete magnesium. So I want you to go ahead and try and do the math and see what you get. Once you've done that, you can unpause the video and keep going. So go ahead and submit your answers. The math here is 3.5 minus 3 divided by 2 times 100, so 25 milliequivalents. Remember that you have to round up or down. It's only in tens, so giving 30 is probably fine. What is the corrected calcium? If you use a math, it's 8.4. So it's actually normal, so you don't need to give calcium. And the patient wasn't having symptomatic hypocalcemia. And I did not give you a QT, so you can't actually assess that. And then if you want to replete the magnesium, it's about 1.5 grams. So you can also go ahead and round up here to 2 grams. So the take-home points are only potassium, calcium, mag, and phos need to be repleted. Replete the mag before repleting the potassium. When appropriate, try oral before IV due to cost and patient comfort. Some hospitals already have built-in repletion protocols, so if your hospital has that, that's great. Here's a summary of electrolyte repletion with all of the details, also a reference for you. All of these things can be found on the inpatient pocket card set. So this is updated annually by myself and many of my colleagues. So here's the link and the QR code. It is case sensitive, so please use lowercase p, c, and s. I recommend that you save this link. This will hopefully have a lot of information for you while you're rotating on the different wards. Finally, here's a list of all the references with the slide attached. So if you wanted to look up a reference for slide 18 of the composition of fluids, here it is for you. And that's it. Thanks for tuning in.